And welcome back. So we'll pick up our story, the inflammatory bowel disease story, by talking about reducing inflammation and irritation as another strategy that would appear to be, a prudent approach. So, reducing inflammatory foods obviously makes sense. The use of essential fatty acids, I'll show you a preliminary study that was done with fish oil that helped to show improvement with these patients. Natural anti-inflammatories, there's some evidence there as well. And also, certain food allergies and sensitivities can trigger that inflammatory response, and these things should be assessed. And often that gets overlooked. So the reason that I know that a lot of this gets overlooked is because a couple of years ago I was asked to give a lecture to the inflammatory bowel disease patients at a very prestigious downtown hospital in the city that I live in. I was asked by the coordinator of the program for IBD patients. I came down and I gave them a presentation that looks a lot like the one I'm giving you, and outlined all these different sort of nutrition and lifestyle strategies that I would think would be a nice adjunct to the standard medical treatment. And they all listened very with tremendous interest. And at the end, they put up their hand and said, how come no one here at the hospital has told us any of this or shown us any of this research? So it just sort of tells me that in certain traditional channels, a lot of this, sort of evidence-based proactive lifestyle intervention material is not really being passed along to patients. And it's still very much sort of a drug-based, approach. And I'm sure that in certain clinical settings, some of this is brought forward. This was just the experience that I had. But I believe that your role here is to try to dissect this, get comfortable with it, and see where it can be beneficial to the patients and clients that are asking you for help. So with respect to reducing inflammation and irritation, it goes back to our story about if there's a lot of arachidonic acid that's esterifying the cell membranes, then in an inflammatory response, and these people have inflammatory responses, that arachidonic acid is going to get released by phospholipase A2, and then through cyclooxygenase and lipoxygenase, you're going to form these inflammatory prostaglandin series 2 eicosanoids, and in the white blood cells, and there's a lot of white blood cells now involved in this immune inflammatory response, they're going to convert that into leukotriene B4, which is very inflammatory. So this is one of the inflammatory mediators. If you can decrease the amount of arachidonic acid and increase, the anti-inflammatory icosapentaenoic acid and or gamma-linolenic acid, then there's evidence to show that that can be helpful for these people. So of course, you know where you're getting all these bad omega-6 fats from, those high-fat meat products, and trans fats from deep fried foods and high dairy products. And then of course the omega-3 fats and gamma-linolenic acid coming from fish and vegetables and flaxseed and borage seed, all these great things. And just another look at it, of course, arachidonic acid with cyclooxygenase moving down this path. So the anti-inflammatories that are sort of gut-specific anti-inflammatories they give inflammatory bowel disease patients help to block this conversion. They're the cyclooxygenase inhibitors that are sort of gut-specific. That's how important this reaction is. They make drugs that can actually help block the inflammatory cascade, but decreasing the amount of arachidonic acid in the body in the first place is the first logical step. And there are no drugs really that block lipoxygenase very well, but there are, of course, things like boswellia that can block that, and curcumin, and we'll see the importance of that shortly. So foods that tend to promote inflammation, we've seen these before: red meat, lamb, duck, and pork, and organ meats, and high-fat dairy, and cheeses that are more than 4% milk fat, and other high-fat dairy products. You're familiar with this list. Things that have a lot of the long-chain saturated fats, and or they have a lot of arachidonic acid. Alcohol is another factor for producing inflammation, and of course trans fats and deep fried foods. So moving patients to protein choices where those fats occur in much lower concentrations makes a lot of sense. So we're back to this sort of list that we've seen many times. I don't need to sort of beat this one into your head anymore, I don't think. Just another way of looking at anti-inflammatory prostaglandins 1 and 3. This is a nice little chart. I thought you might want to see that. And then there is this study where fish oil supplementation at 2.7 to 5.1 grams per day demonstrated an ability to prevent or delay relapse of Crohn's disease and ulcerative colitis. So there is some evidence that if you can increase the cell membrane with EPA, icosapent pantenoic acid, you're going to make more of the prostaglandin series 3 icosanoids that decrease inflammation. And you say, well, theoretically that makes sense, but we have, a couple of studies actually showing that it's actually helped to prevent or delay relapse in both Crohn's and ulcerative colitis. So it just seems like a logical extension to be introducing at least omega-3 fats with fish oil. And, as you know, I like this combination, but if you just want to use sort of fish oil only, then, I don't have a problem with that. And I always like to come back to looking at the composition of the different oils out there in the marketplace, and looking at their saturated fat versus their omega-6 fat like arachidonic acid and linoleic, and then looking at the omega-3 fats they have and the monounsaturated fats they have. Just sort of, look at the amount of monounsaturated fat in olive oil, making it, pretty spectacular, as well as canola oil. And very few of these oils have any omega-3 fat. One of the exceptions, of course, is soybean oil, has a little bit of that omega-3 fat right there. And of course, flaxseed is 57% omega-3 fat, and canola has 11% omega-3 fat. Other than that, outside of fish and fish oil, there's, you don't really see that so much in the plant world. So anyway, I always like to just revisit this once in a while for my own purposes, actually. And we also see that, as we know from the other subjects that I've taught here on the platform, that there are natural anti-inflammatory agents like curcumin and boswellia that can block the cyclooxygenase and or the lipoxygenase enzyme to decrease the conversion of arachidonic acid into these significant inflammatory mediators. And these are not herbs that cause GI irritation or significantly interfere with platelet function. They don't cause bleeding disorders, gastric erosion, ulceration, perforation. They're not known to cause liver or kidney damage over time, or congestive heart failure, or high blood pressure. So what's interesting is that there are some studies that have been published using curcumin, a small open trial with curcumin supplementation with 5 ulcerative colitis patients and 10 Crohn's patients. 9 out of 10 Crohn's patients showed significant improvement, and 4 out of 5 ulcerative colitis patients reduced or eliminated their need for medication, right? So, and then a larger study with ulcerative colitis patients showed that 1,000 milligrams of curcumin twice a day resulted in clinical improvement and decreased relapse rate. So this seems like an obvious thing to want to put into play. Now, 1,000 milligrams twice a day, that's a pretty significant dose. You don't want to irritate the GI tract, so maybe you get 500 milligram capsules of curcumin, and you just introduce 1 and see how the person does, and then maybe 5 days later you have them take 2. Maybe work them up to 2,000 milligrams a day, but I wouldn't start with that personally. And in boswellia, 350 milligram capsules taken 3 times daily showed a similar efficacy as the anti-inflammatory sulfasalazine, which is one of those anti-inflammatories that's gut specific that blocks the cyclooxygenase enzyme. So when they normally would give that drug 1,000 milligrams 3 times a day, instead in the sort of treatment group they gave them boswellia 350 milligrams 3 times a day. I'm assuming that's a standardized grade of 70% boswellic acids. And it got the same effect in reducing symptoms or lab abnormalities of patients with ulcerative colitis. The rate of remission was 82% with boswellia and only 75% with sulfasalazine. So, that's not a huge difference. And maybe if they did the study again, the results would be that the drug outperforms boswellia by 5%. I'm not saying boswellia is better. I'm just saying it's an additional thing that could be added to the treatment protocol during remission to help prevent relapse. Another study showed similar efficacy of boswellia extract compared to mesalazine, which is the other sort of gut-specific anti-inflammatory medication given to Crohn's patients. This is an example of the natural anti-inflammatory supplement I sometimes recommend to patients and other health practitioners. It has curcumin with white willow bark extract and ginger, and boswellia standardized as 70% boswellic acids. Or, what the evidence says is, use curcumin and use boswellia at the doses that you saw, and just, stick with what the clinical studies have shown previously. And then to also decrease gastrointestinal irritation from potential food allergies and sensitivities, I think it's important for these these Crohn's patients and ulcerative colitis patients to actually go through some food allergy testing to see just, do they happen to have, an IgE response to, peanuts, milk, egg, tree nuts, fish, shellfish, soy, wheat, the big 8 that we talk about all the time. Or do they have an IgG positive test, sort of this delayed sensitivity showing an intolerance to certain foods, in which case you'd want to take those foods out of the diet. And then also I would suggest they get tested for celiac, just to see if there's if there's a gluten sensitivity or a gluten autoimmune disease that's concurrent. I would take gluten out of their diet as well, even if that test is negative, to see if the gluten-free diet is helpful. Maybe they have a gluten sensitivity that the blood test won't show. So if it's positive, of course, you're going to reduce the foods that have gluten. But there's also this electrodermal screening. I thought I would talk about it. I don't know how reliable it is. This is sort of based on energy medicine, where they do sort of food sensitivity testing, doing sort of electrodermal screening on the Akabani points with in acupuncture. But there's some people that have gone through this. Suggest that it may have some accuracy. I went through this many years ago, and they said, gee, the only thing you seem to be a little sensitive to is wheat and soy, right? Now, I don't really have a major sensitivity to either one of those things, but if I have a wheat-based product, and then I go for a jog within, say, 40 minutes of having wheat, which I normally wouldn't want to do, but let's say I'm squeezed for time, then my skin might get just a little bit itchy, but if I have other foods, that doesn't seem to happen. So there may be some legitimacy to this electrodermal screening. I don't want to say that all energy medicine is crazy. It might be spectacular. I don't know enough about it. I just thought you might want to read up on it and make your own decision about it. And the next thing, of course, is that you want to improve the gut barrier. You want to rebuild healthy intestinal cells and the lining. So how do you do that? Well, you reduce inflammation by decreasing the foods that produce inflammation, and by giving certain supplements that can tame the inflammatory response, whether that's vitamin D, curcumin, boswellia, omega-3 fats. We've seen them already. And you want to improve digestion, right? So how do you do that? With digestive enzymes, prebiotics, probiotics. You want to eliminate foods that are irritating the gut, so you look for food allergy, food sensitivity, maybe put them on a gluten-free trial, see how they do. And then L-glutamine, of course, is the primary fuel for the intestinal epithelial cells. I would suggest giving them some L-glutamine. So, you can't go hammering away and putting in high doses right away, but you can, sort of gradually put in maybe 1,000 milligrams a day, maybe 2,000 milligrams a day. And then a B50 complex. A lot of these patients have marginal deficiencies in B vitamins. They don't absorb them well. And they also have an increased protein requirement. That's usually because they have a protein deficiency that's accumulated over time because they're not absorbing things well. And reduce foods that are linked to, inflammatory bowel disease, gluten and these sort of other foods that they might be sensitive to. So with L-glutamine, of course, is the primary food for intestinal cells. We know that. It's been shown to support health of the intestinal tract lining in people that undergo chemotherapy and radiation. It helps to preserve the intestinal lining, preventing inflammation from developing in the duodenum, the jejunum, the ileum, and other parts of the intestinal tract and the stomach as well, preventing gastritis. And L-glutamine's also been known to strengthen the immune system. We've seen that in sports medicine, where it decreases upper respiratory tract infections in athletes that are overtraining. And L-glutamine supplementation also increases the synthesis of glutathione, and glutathione is a very important antioxidant, cellular antioxidant, and also a detoxification agent. And in Crohn's disease and ulcerative colitis, you also have this increased oxidative stress. So building up glutathione concentrations in the cell may also be helpful. So this is something that could, glutamine, I sometimes add it to my protein shake or put it into some juice, even if it's just some bubbly water, and just drink it down. Usually it comes in a powder as a rule. And the reason that I talked about those B vitamins is because studies show that patients that have inflammatory bowel disease often have nutrient deficiencies, even like marginal ones at the very least. So 40% of IBD patients show iron deficiency at some level, just low serum ferritin. Maybe they're not anemic yet, but they have that lower iron level that makes them prone to infection. The immune system's not as strong, and you need a strong immune system. 48 have low levels of B12, up to 64% low red blood cell folic acid, and that's terrible. Lower magnesium, low blood potassium, vitamin A, vitamin C, vitamin D. Look, up to 65% have a suboptimal blood vitamin D level, and zinc 40 to 50%. And so these things have consequences. So a high potency multivitamin to try to get that nutritional status improved. The intestinal epithelial cells need many of those nutrients to proliferate every 2 to 3 days to build a healthier gut lining. And so with B vitamins, they're required for energy production in intestinal cells. They do a lot of great things, but folic acid and B12 are also required to make the DNA and RNA so that the cells can replicate normally. And so you should be looking at the patient's red blood cell folate level and also serum B12. These should be tests that should be done as a standard thing. You should say, what is your vitamin D level? What's your serum B12? What's your red blood cell folic acid? What's your homocysteine level, which would be an indicator that maybe folic acid and B12 marginal deficiencies are interfering with the synthesis of S-adenosylmethionine, or maybe the person has a methylene tetrahydrofolate reductase enzyme defect where they can't make that final form of folic acid to methylate homocysteine back to methionine. And so in those cases, the person says, well, your folic acid levels are fine and your B12 is fine, but your homocysteine is high. And in those cases, you would suspect that the person might benefit by giving them additional 5-methylfolate as a separate supplement, so that they can make those DNA bases through the synthesis of S-adenosylmethionine. We've talked about this many times, and have healthier DNA, including in the intestinal epithelial cells. A lot of these things get overlooked in the standard workup, and this is where that second set of eyes is so important. And then with respect to antioxidant supplementation, antioxidants can suppress the production of inflammatory prostaglandin hormones via cyclooxygenase and lipoxygenase suppression, and also antioxidants like vitamin A and D and carotenoids and lycopene and beta carotene. They help with normal cellular differentiation, and this is important for cells to fully mature. Those intestinal epithelial cells, giving them every chance to mature into healthy adult cells so they will function and perform better. And then, vitamin D and vitamin A, they work similarly, actually. When vitamin D comes into the cell, and actually the vitamin D receptor picks it up, and then it binds to the retinol receptor, and then they translocate to the nucleus, and then vitamin D is able to affect certain genes that basically slow down the rate of cell division, help cells mature, and with immune cells, it suppresses their inflammatory response, creates homeostasis. But vitamin D and vitamin A have this effect on cellular differentiation that's so important. And then with respect to oxidative stress, one of the things that we know is that when the macrophages and other immune cells are secreting these high levels of tumor necrosis factor alpha, and we said that vitamin D can help to decrease some of that secretion, which is great. But for the TNF that stimulates the TNF receptor, remember Remicade is trying to destroy that receptor, so it can't respond. But the Remicade wears off after a while, and then things start up again. So when the tumor necrosis factor alpha stimulates that TNF receptor on immune cells and other cells, one of three things can happen. And what happens in these autoimmune diseases is that with the high level of oxidative stress that's with these autoimmune diseases, it tends to follow this pathway over to nuclear factor kappa beta, which releases it from the protein that sequesters it in the cytosol. And the nuclear factor kappa beta now can translocate to the nucleus and then upregulate all the inflammatory cytokines that propagate and cause the exacerbation of Crohn's and ulcerative colitis. So this situation is much worse in a high oxidative environment. When you have antioxidants to suppress the oxidative stress in the cell, then this reaction sometimes changes and you start to get more programmed cell death through the caspase 8 system, and you don't have this massive inflammatory response. So we think that decreasing free oxidative stress, which is a common feature in autoimmune disease, including Crohn's and ulcerative colitis, may hold some promise as well. So this is an example of a high-potency multivitamin that is antioxidant enriched with 1,000 milligrams of C. Here's 1,000 IUs of vitamin D. Here's 400 IUs of vitamin E, a B50 complex. We've seen this before with a little bit of iron, 200 micrograms of selenium to stimulate glutathione peroxidase, a very important antioxidant. And then, of course, other minerals are required to affect other antioxidants in the cell, like manganese as an example. And then there's the protein requirement of the patient with inflammatory bowel disease. So 25 to 80% of patients with IBD shown to ingest less than the required amount of protein. So they really need, because the gut is so damaged, they need to increase their protein intake to between 1 to 1.25 grams of protein for every kilogram that they weigh. And that'll help to support their lean mass, their bone mass, allow the immune cells to make immunoglobulins and cytokines and antibodies. These are all peptides, right? And also for tissue repair and regeneration. Your body structure is protein. You need amino acids to rebuild new tissue. And so getting the protein requirement is extremely important, and getting it from foods that don't have a lot of inflammatory promoting fats is a key factor when choosing the protein that you want to eat. So once again, here's my favorite little protein chart showing the foods that have lower fats, other than, say, fish, which you like the omega-3 fats, of course, but lower saturated fats and trans fats. A chicken breast, a turkey breast, or 3 ounces of a sliced chicken or turkey. There's 25 grams there. Most fish have 15 to 20 grams in the same serving size. 3 egg whites, 21 grams, and so on down the line. And sometimes it's hard to get the total number of grams of protein the person needs, in which case giving them a protein shake might be helpful. Now, some people are sensitive to whey, some people are sensitive to soy, some people, they don't like the taste of egg protein. So you have to try to find a protein shake that is agreeable to them. So, if you've gone through the IgG food sensitivity testing and it comes back and shows that they're sensitive to soy, then, you're going to take soy products out. You wouldn't give them a soy shake. But also, rice protein is showing tremendous promise, as well as pea protein. Just keep that in mind as well. And so you want to reduce foods that are linked to inflammatory bowel disease. It has been hypothesized that changing diets are altering the gut microbiota towards dysbiosis and may thus be driving an increase in the incidence of inflammatory bowel disease. Dietary factors apparently associated with dysbiosis in animal models include, as always, high fat, high carbohydrate, and low fiber diets. So this, you want to give this person a healthier diet to consume when they're in remission, so they can take away some of these offending foods that are likely propagating some of the disease. These diets are associated with lower levels of short-chain fatty acids produced by the microbiota, thereby leading to more inflammation. You want those short-chain fatty acids from the metabolism of the soluble fiber, as you know. And then finally, we get into stress and emotions in inflammatory bowel disease. Stress and emotions can influence the microbial composition of the gut through the release of stress hormones or sympathetic neurotransmitters that influence gut physiology and alter the habitat of the microbiota. So let's look at that carefully. Studies are showing that stress and emotions can actually change the microbial composition and create some of this dysbiosis that we're talking about. And cortisol itself can alter the gut permeability and barrier function and thus contribute to variations in the gut microbiota composition. So we're having evidence to show that emotions and stress really do factor in to the gut, that sort of gut-brain axis, the gut being the second brain. So there's these little charts that sort of show all these things happening, with stress coming from the brain, and then the gut responding by producing all kinds of different chemicals that can then go back and affect the brain itself. But you get all this sort of gut inflammatory reaction from dysbiosis as a result of being stressed out or sort of emotional stress that can trigger the disease and also trigger relapses. So this is a nicer way to actually present it, I think, where you have the brain affecting the microbiota, creating dysbiosis, and the microorganisms now secreting neurotransmitters and other peptides and cytokines that then damage the gut, and then the gut inflammatory components affecting even brain function. So you can change levels of cognitive function, produce anxiety, maybe make autism worse, produce more visceral pain, there's more hypersensitivity, motility, diarrhea. All these things can occur as a result of that. So with respect to stress in inflammatory bowel disease, studies show strong evidence that exposure to stress and release of catecholamines and norepinephrine into the GI tract during stress may be responsible for the dysregulation of the gut-brain axis, changing the GI motility, secretion of mucus and epithelial cells, leading to the different diseases of the gut. Animal studies show this. Stress during the early maturity life, so during early maturity in animals, during the early phases of life, stress produces microbiota changes associated with inflammatory cytokines and increased levels of corticosteroid. So, stress at an early age, remember that these diseases occur at an early age. Starting at age 15 and up to age 35 is when Crohn's disease and also ulcerative colitis are likely to begin. So stress may also be factoring into how the gut is responding through changes in the microbiota. So this article in the Harvard Gazette in May of 2015 is interesting, looking at meditation and progressive relaxation. A pilot study has found that participating in a 9-week training program, including elicitation of the relaxation response, had a significant impact on clinical symptoms of the gastrointestinal disorders, irritable bowel syndrome, and inflammatory bowel disease, and on the expression of genes related to inflammation and the body's response to stress. So we actually have some early human studies that getting people into a more relaxed state through guided relaxation and meditation as well, I would think, is going to have an important effect on the gut and some of the inflammatory mediators. So the way that I try to help patients put this together in terms of meals, this is just my own thinking now, is that I like them to have a low-fat protein selection at the center of the meal. I want to try to get them enough protein through the day now because they're often deficient, and surrounded with 2 to 3 sort of healthy carbohydrate selections. So I'll just give you some examples. If they could handle low-fat yogurt, say a Greek yogurt, they might have some high-fiber cereal with a few berries, or maybe it's a protein shake with some ground flaxseed and maybe some berries in there. For lunch, it might be a chicken burger or a veggie burger or a turkey sandwich on a whole wheat bun with tomatoes and lettuce and a small salad with oil and vinegar, olive oil and vinegar. At dinner might be broiled salmon with maybe broccoli if they can handle cruciferous vegetables, and a small fruit salad, and have them choose their snacks through the day, without a lot of the bad fats in them as best they can. And consider functional foods in their diet. Try to get them to live bacterial cultures. I showed you an example with low-fat yogurt, but also including sauerkraut and kefir and miso, and maybe pickles. Kimchi is fantastic. The 14 mushroom blend that I order from mushroomharvest.com, I think is spectacular. It says 2 teaspoons, but I wouldn't start an IBD patient on 2 teaspoons, maybe half a teaspoon to see how they do, sort of mixed into a little bit of juice or into some yogurt possibly. And then vegetables that have the FOS and the inulin, and the fruits that have the FOS and the inulin as much as possible. Artichokes and maybe bananas, and using onions, some garlic if it doesn't overstimulate the gut. And try removing the highly allergenic foods such as wheat, corn, and non-fermented dairy products, and ensure adequate fiber, low sugar, and refined carbohydrates. I think that's, a prudent approach. In terms of supplements, probiotics, I think, is a given, and then sort of digestive enzymes with prebiotics, or they can be done separately. There's a supplement that I like that has that's a full spectrum, high potency digestive enzyme that also has prebiotics in it. And then essential fatty acids. It could just be fish oil, but if you like, I like this combination personally. And in natural anti-inflammatories, curcumin, boswellia, we've talked about that. A high-potency multivitamin to correct the underlying nutrient deficiencies, and look at their blood level of folic acid and B12 and homocysteine as part of the workup, and their serum ferritin, and their blood vitamin D level. That should all be factored into the standard blood work. And if necessary, then additional vitamin D, as we saw, 2,000 to 5,000 IUs a day, improving outcomes for these patients, and possibly adding L-glutamine slowly over time to improve immune function and give the intestinal epithelial cells the principal food that they like to consume. And immune cells also use L-glutamine as an important supplement. And then with respect to, as an important modulating factor to decrease, infections. And then in terms of mind-body, you want to try to reduce the release of stress hormones and calm the nervous system. And so this is where meditation comes in, and progressive relaxation, maybe yoga, moderate amounts of physical activity. If they push too hard, that's stressful. It could actually exacerbate it, but moderate physical activity makes sense, so you're not over-secreting cortisol. And that takes us to the end of this section. When we come back, we'll pick it up with a discussion on diverticular disease.